what I'm going to talk about is proximal junctional kyphosis and failure, and differentiating between the two, why it matters, and theoretically how we can then reduce this in adult spinal deformity surgery. But then also I'll have a chance to go in the lab and demonstrate some of these techniques. There we go. So if you look at proximal junctional kyphosis and failure, we'll use PJK and PJF as abbreviations for this. We know it's problematic in spine surgery, right? Associated pain, deficit, and revision surgery, and relatively high rates associated with it. Boachi reported about a 22% rate. Virginie Lafarge, who Dr. Debussy knows quite well, was one of her protégés. In PSO for adult spinal deformity, about a 40% incidence, and then we reported, and this is in line for publication currently right now, incidence of junctional failure, about 14%, with revision surgery rates about 7.5% in patients. The problem, though, with PJF is that it remains problematic despite all the research that's been focused on it, because of the methodologies within it, and namely, how do we define it? And the problem is, we can't prevent something if we can't define it, right? And so currently, it's a radiographic definition because that's the easiest way to do so. And so it's 10 plus 10, right? So the angle between the UIV and the UIV plus 2 has to be 10 degrees and 10 degrees greater than it was preoperatively. The problem, though, then it's going to range from the spectrum of benign kyphosis all the way to catastrophic failure. And if you look at those rates previously reported, Obi Boachi was reporting on this. He was reporting on the benign PJK, whereas our two studies within the ISSG that I just referenced are focusing on junctional failures. And so there's really no control, and it's this mishmash of this phenomenon that's being reported. The other problem, though, is also there's many confounding factors: age, amount, degree of correction, fusion to the pelvis, primary versus revision surgery. And so then if we look to then solve this, the problem is severalfold. One, you have to define it accurately. And two, you say, well, what are then the solutions for it by controlling for all the confounding factors? And so let's take a deeper dive into what's been proposed to prevent junctional failure, namely either implants or, as Dr. Debussy was talking about earlier, spinal alignment. And so if you look at the biomechanical theory behind PJF, right, it's construct rigidity, namely an abrupt change between the non-mobile instrumented segments and the hypermobile non-instrumented segments. And if you look then at the solutions, they've either been implant-focused to prevent and dampen the proximal forces, right, hooks, transition rods, and tethers, or to harden the proximal vertebrae, either the UIV or UIV plus 1 or UIV plus 2, even vertebroplasty. And we did two papers on this through the ISSG, both finite element analysis paper, looking at a model from T7 potted then at the pelvis, and then at the UIV, we looked at different configurations: hooks, screws, and or tether. And I'll come over here and show this to you guys. So the red here is the UIV, right? Next one is the UIV plus 1. PS is pedicle screws. TPH is hooks. And then as we then go across, I think this thing is, ooh, it's very fancy. You can do a tether at the UIV plus 1, UIV plus 2, and UIV plus 3. And what you see then, right, with pedicle screws, you see this abrupt transition from the UIV to the UIV plus 1, right? And that's where some parties are thinking that junctional failure comes from. It's this massive change of force, range of motion, UIV, UIV plus 1. If you look at a transverse process hook at the UIV, you see it dampens it a little bit, but you have this enormous gradient. But then as we use tethers at the UIV plus 1, UIV plus 2, and UIV plus 3, you can see you have this much more even dampening effect as you go across to those segments that are theoretically non-instrumented and not part of the pedicle screw construct. So then we looked at, as a second publication, looked at different configurations of the tethers, right? Because you can either put it just at the UIV plus 1, just at the UIV plus 2, or you can weave it in, but then you also have to tension the tether. And then what does tensioning then do to the construct? And through that then same model, we found that if you include the UIV plus 2, it's the most effective, namely it dampens those forces most effectively, but it doesn't matter if you weave it or just include the UIV plus 2, because if you tension it, it applies load to that construct. But here's something that's very interesting, is that if you don't tension it at all, right, it has no effect whatsoever, which makes sense, right? Because all you have this tether that's floating in the breeze. If you tension it to be about 50 to 100 newtons, that's ideal, right? It's going to dampen those forces. But then if you over-tension that construct, if in fact the bone interface will maintain it, it's detrimental. And why is that? Because it turns the construct now into essentially a pedicle screw, right? It makes sense. If it's over-tightened, then it's going to fail with the same mechanism that an all-segmental screw fixation construct would behave, right? And so, again, there's this ideal tension. There's a caveat, though, to this that we found, is that we haven't been able to tension the constructs enough because the failure patterns of the tethered constructs are not the same failure patterns as the all pedicle screw constructs. The pedicle screw constructs normally fail at the UIV, which you saw previously, compression fracture, and the UIV plus 1 falls over the top. What we see with the tensions, with the tethers, the same thing is happening. The UIV is failing at the pedicle screw, and the tether is ripping out. So, based on that scenario that I just painted for you, then clearly implants are not the solution, and it's probably a thought behind the company product saying this is going to be a solution for all your surgeries. But what we all know, and everybody in this room will attest, that they've not been 100% effective in preventing junctional failure. And there's been less focus on alignment to try to prevent junctional failure. And this is what Dr. Debusset was alluding to earlier this morning. We then did a subsequent study looking at age-adjusted alignment parameters, right? And we know as people age over time, age is a kyphosing event. And what we did, this is Renaud Lafarge. You know Virginie, but I don't think do you know Renaud, Dr. Debusset? Yeah. You know who Renaud is? Okay, so you know his whole family. So Virginie and Renaud are both in our group. And this is Renaud's initial study, looked at adult deformity patients with no surgery, divided them into age cohorts, and looked at the health-related quality of life for those patients. And then based on the norm on the ODI, which is right here, and the SF36 PCS, took the sagittal alignment parameters and then applied that then to those generational norms, which is where we get these values for pelvic tilt, pelvic incidence minus lordosis, lordosis gap. We all know these parameters at this point, hopefully by now, and SVA. And as you see over time, the patients, as they age, they normally go forward. So what does it matter? Well, that matters because if I take the 74-year-old and I say, wow, their SVA is 80, it's out of whack, I'm going to put it right back to maybe neutral or 5 degrees. That patient probably should not be there and is at risk for junctional failure. And the question is, why does that occur? It's this concept of the extrapolated SVA. If you overcorrect, you can see how these two patients have failed. But if you look at where their head would have been, if we extrapolate it from the construct, their SVAs are way negative, and there's no way they can maintain that alignment. And by the way, here's that same failure pattern. Pedicle screw at the UIV fails through a compression fracture, UIV plus 1 fails over the top. It's almost always consistent. So then, based upon this intolerable alignment, we'll call it, Renaud did a second study looking at the risk factors for overcorrection of SVA and PI minus LL, and we found actually that PI minus LL is the most accurate because you don't compensate through the PI LL. It's almost always within the construct, right? Because the construct almost always goes from L1 to S1. So it's going to be a reliable measure. We found that with increasing overcorrection, there is an increasing PJK angle. Namely, not only is there an overcorrection failure, but the more you correct, the worse they then fail. The other problem then is the location of lordosis and junctional kyphosis that were noted as well. Namely, if you take the lordosis higher into the lumbar spine, they're at tremendous risk for failing, right? The patient anatomically needs to have lordosis down here. I realize there are sagittal alignment parameters, and some patients have a normal junctional kyphosis at the thoracolumbar junction. However, if you postoperatively look at your radiographs and you have trapezoidal disc spaces up by your UIV, it means that you've transferred that load up to the UIV, and you are at extreme risk for failure for these constructs. So then, based upon those 3 prior studies, we did this, we presented it in Bologna this year, and it is in submission and revisions right now with spine. We wanted to look at and compare then the efficacy of implants versus correction to prevent junctional failure and revision surgery for junctional failure. So we did this study, which is a propensity score match analysis for patients within the ISSG database. It's a prospective multi-center database that Bob Hart told you about. Here's the inclusion criteria for the database, and then the study inclusion criteria, obviously surgery, minimum 5 levels fused, but then also minimum 1-year follow-up. We took 1-year follow-up as opposed to 2-year follow-up because we found the vast majority of junctional failures occur within the first 6 months. And so then the way we did this methodologically is we took the initial data set, and then rather than using historical factors for our PSM, our propensity score match analysis, we looked at them within the cohort. So we looked at risk factors within that cohort for junctional failure. Then based upon those confounding factors, we then ran the PSM and then divided the patients into several cohorts. First, right, use of implant prophylaxis versus none, right? The patients that get either a hook, a tether, or cement at the UIV, named the type of prophylaxis. And then we looked at patients that were overcorrected, which is right, so that's gonna go past right there, versus those that remain within alignment. And then for our definition of PJF, we looked at patients that had revision surgery for junctional failure and then applied that using this mathematical algorithm, which you see here and here for the upper and lower thoracic spine, that again, Virginie and Renaud Lafage have since validated. And so here we find here, this is prior to the PSM. Again, the bottom line here, within the cohort, about 80% fuse the pelvis. PJF rate about 14%, revision rate about 7.5%. And then here's our PSM, I should say, the risk factors for junctional failure: age, frailty, pre-op deformity, fusion of pelvis, and correction. We obviously also found that age overcorrection was a risk factor, but you can't use that in the PSM because it'll destroy your study, because you're controlling for a variable that then you want to analyze. And then based upon that PSM, using those variables highlighted then in yellow, we then ran our first analysis. And you can see for the none versus the implant group, we see the PSM actually worked. Same demographics, pre-op deformity, surgery correction, as well as age overcorrection. And we found actually that implants work, right? If you take patients that did not receive anything for PJF, incidence of junctional failure, 20%. Those that did receive something, about 10% decrease. So the junctional failure rate is about 10%, although there was no difference in timing or revision rates for PJF. We then looked at the efficacy of hooks compared to cement, compared to tether versus none, and actually found that hooks performed the best. Red here is the PJF rate. Yellow is the revision surgery rate. And you can see this drop. Right, oh, the normal one. You can see this drop from here down to there. They're all lower. Hooks perform the best, but we think that's an N problem. Namely, we think that the cement and the tether groups were not powered enough to do it. But I think what it's showing us in general is that implants work. But then if you look at alignment alone, if you take patients that had no prophylaxis, but you didn't overcorrect them, compared to patients that had no prophylaxis and you did overcorrect them, look at the drop in junctional failure. 24.2, almost 25%. So 1 in 4 patients is going to fail if you overcorrect them and you put in no alignment, or no, if you overcorrect them and put in no prophylaxis. But look at the decline in the alignment group, down to 13%, almost cut in half. And look at the revision surgery rate. Way, way, way down. So it's amazing, despite having all this teaching that you should use a tether, you should hook, or you can put in cement, just paying attention to preventing overcorrection for your patients can cut the PJF rate in half and the alignment rate, or the revision rate, almost 5 times. Amazing. And so then if you look at the performance then, if you combine implants and alignment, and if you do nothing, look at the dramatic drop down now. So if you do nothing, you don't put a hook, you don't pay attention, you say if PJF doesn't matter at all, I'm just going to throw something in, and oh, by the way, I don't care about alignment whatsoever. About 1 in 4 patients is going to fail. And if they do have surgery, about 11%, almost 12% of those patients are going to have revision surgery. And there's going to be some outliers that don't have surgery because they're so pissed off or they go someplace else. If you, again, don't put a hook in, but you maintain the alignment, massive drop down, again, in PJF as well as revision surgery. These two are similar, namely, alignment had a similar effect as then the implants. And then finally, if you combine the two, this p-value was roughly about 0.06. So it's probably, again, a power thing, right? And so if you combine some kind of technology, prevent junctional failure, as well as pay attention to alignment, the rates drop down even further. So in conclusion, if you're going to chew off these cases, and you're going to be, especially an adult spine deformity surgeon, and you don't pay attention to the incidence and the risks for junctional failure, at least 1 in 4 of your patients is going to incur this complication. So you have to pay attention to it, but just slapping in a hook or slapping in a tether, it's not going to cut it, despite what the implant companies tell you, right? You have to be a thinker. You have to pay attention to alignment. And if you can then measure our alignment, or your alignment, avoid overcorrection, and then put something smart in up top and theoretically dampen those forces, it's going to be much, much more effective. Clearly, the research in this, one has to focus on the definition so it's accurate, but also rectifying our intraoperative alignment from our preoperative plan. Right now, we don't have a very good way. You can get a C-arm, you can measure. So I get a C-arm shot at the very end, measure lordosis, compare to pelvic incidence, and then I get a folding scoliosis film and do the same thing. But then also finding the most appropriate implants to prevent this phenomenon. Thanks.